Hi everybody, my name is David Petrino. I'm the Director of Rehabilitation Innovation for the Mount Sinai Health System. I'm here at Aspen Ideas Health talking to Dr. Louis DiPolo, who is a professor of pulmonary medicine at Mount Sinai, and we are going to be speaking a little bit about long COVID.
Thank you, David. Thank you for inviting me. It's great to be in Aspen. Great backdrop. Thank you so much.
Very nice backdrop,
Thank you.
Absolutely. So we both see a lot of people with long COVID, but I think it's important for us to talk about the idea that long COVID is so many different conditions all being pushed into one diagnosis. And so I thought it would be nice for us to talk about the idea that we can have many different types of long COVID treated in many different ways. And what we as clinicians need to start to become comfortable with is understanding how two different people with the same diagnosis could be treated in completely different ways. So, I mean, maybe to start, could you tell us a little bit about your experience with treating long COVID?
That's exactly correct. As a pulmonary critical care doctor, I saw people in the ICU, and then I saw people in the ambulatory setting. We got to share some of those patients during those early days.
Yeah.
So someone who's in the ICU and winds up on a respirator and has pulmonary fibrosis or renal failure or heart disease, they may be tagged with that for the remainder of their life because now they have end organ disease and they may need to go to lung transplant or even heart transplant, or they become a cardiac cripple. Is that long COVID? They certainly have now a lifelong disability. But then you have in the ambulatory someone, brain fog. These marathon runners who lose their exercise capacity, they were able to ride 5 miles, now they can't walk 5 feet. That's a different phenotype. Should we be lumping them together? Probably not. You know, we are learning as we go along. We have blunt tools to figure this out. So I think you're right. Our next stage is to separate them out. And the reason why we can lump it all long COVID, end organ is a very different disease than brain fog, autonomic dysfunction, what we've talked about, the lightheadedness, the feeling faint. So you're right. We can treat same diagnosis very differently depending on what the patient is left with 2 weeks, 4 weeks, 8 weeks later.
Yeah, absolutely.
8 years later. We don't know yet.
We don't know yet. No, I think that's a really important point. We don't know how long these symptoms are going to last for. And certainly with people with end organ disease and people with not necessarily end organ disease, but organ damage, we at least have a bit of a roadmap. We at least have an understanding that someone with damage to their lungs after experiencing a severe pneumonia, they can enroll in a pulmonary rehabilitation program and do quite well. But if you take the person that you were speaking about before, the marathon runner with brain fog and post-exertional symptoms, and you put them into a pulmonary rehab program, they're going to crash, and they're going to crash badly. So have you found any wisdom or experience in managing the expectations of individuals who are coming to you for care and doing no harm in the first place? Right. Because I think that's a very important part.
I think that's a very important part of what you described. In pulmonary rehab, we try and encourage people to do all they can to push to the limit. So we took that experience that we had, and then we applied it early on in the early days to the long COVID patient, and we failed miserably. And the patients were dissatisfied, the providers were dissatisfied, and we learned very quickly, much with your help and your publications, to realize that that's not the way to go. So the encouragement to the individual is we have to figure out who you are, what your limitations are, and set expectations. Those expectations are changing as we learn more and as you learn. So it becomes a true partnership between the patient, and we have to listen to a patient because we're going back to school. We have to listen to our patients, find out what their symptoms are. Don't carry the baggage of old pulmonary rehab where we push you as hard as we can and then learn as we go along. So that's, if I take any take-home message, the long COVID patient must partner with their provider to figure out what their path is. And we're finding out there are many individual paths.
I think that's so on point. And I think both of us have the privilege that we have tended to work even pre-pandemic in a space where we were very focused on personalized medicine. We were both very focused on viewing patients as partners as opposed to, you know, an older-fashioned idea of I'm the clinician, you're the patient, and there's a one, you know, the information flows in one direction only. I really agree that we need a very significant cultural shift in the way that we're practicing medicine right now to make sure that more people are experiencing this level of partnership.
And it's not one size fits all. It's
Absolutely.
so key. So basically, as a pulmonologist of certain years, I had to throw out the book and start to learn with my patients and from my patients.
Yeah, absolutely. And I mean, we always have this adage that that has been drummed into us from the beginning, that exercise is medicine. We've always viewed this as no matter what, if you can get a patient to exercise, you're going to make them feel better. And when you talk about throwing the book away, this is, you know, something that the myalgic encephalomyelitis and chronic fatigue community have known for a very long time. But if exercise is medicine, well, let's treat it like medicine. Let's make sure that we dose it appropriately. Let's make sure that we understand our patient's physiology before we prescribe it. And let's also understand that there are patients who are going to be contraindicated to this medicine. They are going to get worse if you give them exercise as a medicine as opposed to better.
Right. And the hope will be it's the wrong medicine today, but that perhaps in the future, as the patient continues on their journey of recovery, that exercise down the line might, in fact, a time when it will be appropriate.
Exactly. Absolutely. Lou, thank you so much for joining me in this amazing setting once again and this great discussion.
Well, David, I want to thank you. I want to thank you on behalf of myself and my patients because you've taught us so much. You're going to continue to teach us, and we will work together to really address the needs of our patients. So thank you.
Thank you.